Praline, who will be singing the national anthem for us. Please feel free to join in as well.
Good evening, everybody.
Kosisikele Afrika, malapaganyisi punulwayo, iswayemitanda soyatu, kosisikele tina lusapolwayo, morena siCgWA AyFzI7dCgWA usibuluke siCgWA South Africa, South Africa. Die blauwvan ons hemel, die diepte van ons ziel, waar ons ewige geboortes, waar die grenzen wordt viel. Sounds the call to come together, and united we shall stand. Let us live and strive for freedom in South Africa, our land.
Thank you.
Thank you, Dr. Praline Ross. Just one more time, she's so sensational. What a beautiful voice. Thank you very much. In the company of such esteemed guests, it's quite overwhelming. So just bear with me. Welcome to our first of what is probably going to be many solutions-driven symposiums. And we're calling it #Let'sFixSA. So thank you once again for being here. Dignitaries, healthcare executives, colleagues, and fellow patriots, all protocol observed. South Africans are resilient. There isn't a nation in the world that can come together when it matters the most and overcome the unthinkable. But we are getting tired. And there's only so much that we can overcome time and time again. Doing the right thing in this country, doing your job to the best of your ability, can get you killed. I considered starting our campaign, #Let'sFixSA, on a cheerful note, but it's time to be realistic. 11 lethal bullets ended the life of a woman, a single mom who was only guilty of doing her job diligently. Babita Deokaran exposed irregularities at Tembisa Hospital, and she paid with it for her life. Her blood was never in vain, and today we are seeing the rats come out of the shadows. Whether they suffer the consequences, however, remains to be seen. We must fix this place. It's not going to be easy. When my son, my little boy, he was born with a congenital heart disease, an AVSD, I think the term is. My wife and I were naturally overcome with anxiety. But we received the best possible medical care that only a monthly premium religiously taken out of your account would make possible. Thankfully, today our boy is healthy and strong, but there are more than 3,000 children on waiting lists in state hospitals for similar procedures. And I'm probably preaching to the choir, but often a simple intervention could mean the difference between a quality life or worse. Poverty should not be a death sentence. I know there are two major issues in this country, and I'm sure you'll concur. It's inequality and corruption. but it's up to credible and high net worth, a high net worth of integrity, which is bountiful in this room and beyond, to do something meaningful about it. This evening we have a powerful panel who volunteered their valuable time to be here, so we can expect robust conversation, but we must keep it respectful. There's a fair amount of uncertainty around the NHI bill, and yes, we have more questions than answers. But here is a platform for some clarity and understanding. Today marks the beginning of intentional collaboration, of difficult but necessary conversations, of bold ideas taking shape, and of a shared vision for a healthier, fairer, and more united South Africa. Welcome to the Inclusivity in Healthcare Symposium, where Let's Fix SA sector by sector starts to truly take shape. We kick off today's proceedings with an address from entrepreneur Nelly Nkobo, who, mind you, is at the cold face of inequality, and she operates from Zululand. She runs a private paramedic service. That will be followed by Deputy Director General Dr. Anban Pillay, then Professor Nicholas Crisp, Professor Morgan Chetty, and finally Dr. Imtiaz Suleiman, who I'm sure is still on his way. A few house rules, ladies and gentlemen. Bathrooms are to the right, exits to the back. Dinner is buffet style with halal options. Your starters are halal, mind you, and you'll have to trust me on this. Yeah, and I will now hand over to our facilitator, Desan Tatia, who's going to start our proceedings and get down to the business of things. Thank you, ladies and gentlemen.
Good evening, ladies and gentlemen. I was remarking to someone that I find myself in a bit of a different setting to where you would normally see me, but nevertheless, I'm equally excited to be here and in the company of such great individuals like yourselves. An absolute honor to be here and to facilitate this session. Really can't wait to get going with our panel here. In fact, I wonder if we're going to keep to that time that's on this television screen right now, because there are surely a lot of questions. So, as Rowan just mentioned, the first speaker is Nelly Nkobo, who is an entrepreneur, and she is, just a little while ago, I was chatting to her about what it's really like. You know, I was sharing some of my experiences that I had gotten just relayed to me by the individuals that I deal with in the private sector, particularly those paramedics that are out and about 24/7 and taking those that need that healthcare, dropping them off at state facilities. And we were I was just remarking to her that I've heard some horror stories. And, you know, one of the things that Rowan has been preaching is that this is a frank conversation. We can't fix any problems if we are not honest about what the problems are. So with that, to set the tone, I now welcome Nelly Nkobo to join me up here and share some of her experiences. Thank you.
Good evening, ladies and gentlemen. My name is Nelly Nkobo. I'm a co-founder of Afromed Medical Services, operating in Umhlaba, Uyalingana, and eThekwini districts. Our journey started in 2012, and over the past 13 years, we have become a small but determined medical emergency sector in KZN. I want to start with a personal story. I grew up in Tuzuma Township, which is under eThekwini district, raised by a single mother who worked hard and earned little, but who never stopped believing in my education. Because of her sacrifices, I finished my grade 12 and able to pursue my training as a paramedic. In 2005, I did my in-service training at the company Eximed Response. Mr. Januk is here. Can you please rise, Mr. Januk, so that they can see you? That is my father in business. Thank you for being here. He gave me a chance, mentorship, eventually employment, and his support have become a cornerstone of everything that followed. Community members will normally come knocking at my home whenever there is an emergency, as they believe that as I'm a paramedic, if I am calling for an ambulance, it will respond faster. The desperation made me realize that there is a serious need for an ambulance to service our communities. In 2012, together with my business partner, Sembiso Ngubo, we imagined something that felt audacious at the time, our own ambulance company. Focusing and serving lives in the township and in the rural areas where the emergency medical services were scarce. That idea became a conversation because we couldn't afford to purchase our own ambulances. We approached every financial institution to assist, but there was no luck. Because we had an idea, but nobody believed in us, it meant we must do it ourselves, no matter what. We then started going to school, selling first aid kits, providing first aid trainings and demonstration. We also providing medical services on the special event so that we can purchase our own ambulances. That's how we managed to buy our first ambulances. Thanks to persistence, teamwork, and continued support to people like Mr. Januk, that plan grew into AfroMed Medical Services. Today, we operate 11 ambulances, employ 60 full-time paramedics, and engage up to 30 part-time paramedics each week to cover events and peak demands. We save community from branches, Durban and Manguzi in Mhlabuyalingana. What began as a simple plan in Manguzi branch has become a real, living commitment to transform lives there and surrounding areas. For those communities, the long, expensive journeys to access private care has become safer. The reality that the people like, the reality is that people like the ones living in Mhlabuyalingana district has very little access to quality private health care, and they are forced to often travel more than 200 kilometers in order to get a basic treatment. The promise of the National Health Insurance represents hope. Hope that no one should be denied care because where they live on how much they earn. But the policy is only as powerful as the system that it supports. To release this promise, we need practical urgent steps. We must expand hospital capacity in underserved areas like Mhlabuyalingana. Invest in emergency services and ongoing training of frontliners providers, and build stronger public-private partnerships so resources, expertise, and infrastructure work together rather apart. It's not too late to fix South Africa, but it will require more than good intentions. It will require an unwavering commitment, significant resources, and courage to decisively starting now. We must invest in people and system, empower local leaders, and measure our progress by lives saved, suffering not averted. As I look to the future, I am positive. I have seen what a small focus team can accomplish with dedication and the community support. I have watched young paramedics grow into leaders. I have seen the relief of families' faces when help arrives in time. Those moments remind me that change is possible. Let's continue to lead with compassion and commit the practical action and stand together until quality care is a reality to everyone in the country. I'd like to thank my business partner, Sembiso Ngubo, for being here, this evening and looking forward to engage further. Thank you.
Thank you so much, Ms. Ngobo. We appreciate your inputs. You know, some of the conversations that we were having before this were quite interesting because I think on a high level, many people can agree that we all want the same thing. And we want this inclusivity that we're talking about, and we want equality, and we want everyone to have the same level of healthcare that everyone deserves. I think the issues that have arisen is exactly how that will be done, how it will be funded, and whether the country as a whole is capable of doing that, considering the state of some of our healthcare facilities. So now we'll get some input from the health department. We will get Dr. Anbin Pillay, who will be giving us a little bit of insight. He finds himself in an, I suppose, in an unenviable position to have to answer some of these questions and explain a little bit further, but I know that he'll do it with ease, along with his colleague, Professor Chris. But please come this way, Dr. Pillay. We'll appreciate your time.
Here's the clicker. This one. Thank you very much, and thank you to Rowan for organizing this. This is quite an innovative idea. I hope that it develops into something much broader for other sectors as well. It's important to have these kinds of conversations. So I hope you continue to do so in KZN and maybe across the country as well. Sitting at the table, I noticed the water is branded Cubana and has Che Guevara's photo on it. And I was thinking that, many of his principles that I'm sure myself and Professor Crisp are going to talk about are things that you may not necessarily like, but that comes from him very, very often. And I think it's important to, as we appreciate the venue, also think about some of the principles that Che stood for when he developed the health system in Cuba. So the way we've thought about this when I spoke to Rowan is I'll talk about the more immediate health challenges and how do we deal with that. And Professor Crisp will cover, obviously, the NHI issues. Not to say that either are not important, so I'm just gonna not overlap with things that relate to the NHI. And I was given 10 minutes, Rowan. I know I'm not sure if I'm going to be able to do it in 10 minutes, but I tried to keep it as short as possible. I think it's important for us to appreciate the constitutional imperatives that we have in the country. Secondly, what is the quality issues of care in the public sector? And thirdly, talking about the private sector and what those challenges look like. So I think looking firstly at the constitutional issues, if we look at the preamble of the World Health Organization, the minister loves this and he can actually say this by heart. He'd be quite upset with me that I can't rehearse it like that, but I'm going to try. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic or social condition. I mean, it goes on to talk about other things. It also says that governments have a responsibility for the health of their people, which can be fulfilled only by the provision of adequate health and social measures. So there's a huge obligation on us to recognize that health as a right, and governments have a responsibility to make sure we fulfill those rights. If you come now to our Constitution, Section 27 of the Constitution is quite clear. It says that everyone has the right to access healthcare services, including reproductive health care. I'll skip the other parts so that I stick to Rowan's time. And the second part says the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. So government has to, within its resources, move towards the achievement of these rights. It also says no one may be refused emergency medical care, and we can talk a lot about how some of those remain challenges, I think, particularly given the previous speaker's discussion around emergency medical services. So in terms of our constitution, the state has a very clear obligation to ensure access to health care for all. In fact, somebody could take us to court and say, well, here is what you are obliged to do, and these are the measures you should be doing. So our failure to do so also has a problem on the other side. So it's not as if you simply fold your hands and say, well, I don't have money, or I can't do this, etc. It's a comfortable position. You can also be challenged for this, and we have been challenged in many cases. So what do people often have a problem with? And these are the things I think many of you in the room, when you talk about the public health system, will raise. The first is the cleanliness of the facilities. When you go into a facility, there's a problem in the facility. Secondly, people will complain about waiting times in the facilities. Thirdly, there'll be issues relating to availability of medicines and equipment and complaints linked to that. Sometimes the attitude of staff in facilities and the infrastructural needs. So those are, I think, broadly speaking, what most people talk about when they have a problem with the public health system. People don't talk about the clinical care in the public health system because I guess they're unable to engage whether the quality of the clinical care is appropriate or not. They're talking largely about what we call the hotel services. And these are the areas that we need to get right as a public health system in order for us to be able to improve the quality of care as we implement the NHI as well. And I'm sure Professor Chris will talk about this. But as we do that, I think it's important that we appreciate some of the differences between the public and the private system, because we often, when we engage on these issues, we are engaging relative to something else, and we are making a comparison. And I'd urge you to think about this comparison carefully. In the public system, we are financed, and you may know this, through transfers from the National Treasury. So the Treasury transfers funds to provincial departments of health, and funds then come to hospitals and clinics, and etc. Based on that funding, anybody that walks through the door, the public system has to deal with, right? No matter what's wrong with them. They don't have a filter. They can't ask them, do you have a card? Can you enter? Anybody can enter. So we have to deal with everybody that comes through, which is very different from the way the private system operates. The private system operates on the basis that you participate in a medical scheme most often. And once you're a member of a medical scheme, you then enter a private health facility. And based on that, that's a basis on which you access care. If you don't have the cash, you won't be able to access the care. So there is a basis on which you can limit access through a private system. 85% of South Africans, you probably know this, rely on the public system for care. And on the private side, 15% of the population do that. In the public side, we do charge user fees, but it's minimal. I mean, we could actually state that we're providing free healthcare services because the extent to which fees are collected are fairly limited for a variety of reasons. And in the interest of time, I'm not going to go through that. Medical schemes, on the other hand, have contributions. So people decide to contribute to medical schemes, and these are voluntary. The employers also subsidize that to a large extent, as well as the tax credits that come through the tax system when you complete your taxes. But here's the point I really want to make. If you look at the expenditure in the public health system on a per capita basis, this is just at a rough level. On a per capita basis, we spend about 5,323 rands per capita per annum. And I'm not even adding what the foreign nationals access in our system, right? I'm just taking the South African population. On the private side, per capita, we spend 28,700 rand. It's a 5-fold difference. When you have such big differences between one sector and another, you will have distortions. There'll be massive distortions. One clear distortion is going to be human resources. If I'm somebody who's going to be able to access care, deliver services in the public versus the private, and I could earn more in private, why would I stay in public? Work hard the whole day, don't have equipment, all of the problems that you have. I would move to private, right? And that's what happens. Equipment is another problem. So you're having to finance this with the budgets that you have. Then you have limited human resources and you have long waiting times. So it's a vicious cycle. And so you need to understand where the public system is currently given the challenges that it has. So quality of care in the public system is clearly a huge issue for us. And for that reason, we've established the Office of Health Standards Compliance. And this office has set out a set of norms and standards by which it goes out and inspects facilities and declares whether a facility has met these norms and standards and certifies them. But there's also an internal process of thinking of quality in terms of the norms and standards by which a facility must operate. Now, clearly, we'll never be able to change everybody overnight, but certainly this is now the culture within the organization, that you need to comply, you need to explain why you failed an inspection, what are the factors that have affected that, and how do we improve that. So clearly we've moved the system away from simply a system that says, well, patients come in and you treat them. How you treat them is not really a problem. That was a previous system. The current system is we got to adhere to the quality standards that we have, and much of these indicators are on the website of the OHSC, and you can find them there. I think it would be remiss of me not to talk about the essential elements of a quality health system. And these are the 6 elements that relate to a quality health system. You've got to have effective leadership and governance, effective supply chain so that you can have access to medicines and other equipment, appropriate management of your finances, and I think a lot can be said about that around corruption and fraud and all of that, maintenance of the health infrastructure, adequate information system so you're able to make decisions about how you deliver services and how you manage patients, and an appropriate mix of skilled professionals. So these are the 6 building blocks largely on what health systems are made of. And when we look at our health system, the public system or the private system, we would measure them against these building blocks. And if you listen to a lecture from the minister, he'll always have this slide. So I was worried in case he pitches up and says, where's that slide? So let me pick a few because I don't have the luxury of time to deal with all of them. But I think on the first issue, let's talk about effective leadership and governance. We'll find that in the poorly performing facilities, we have managers that don't necessarily have the appropriate skills and experience to deliver on those services. If you think to the past, a person who became a hospital manager, who's somebody who was a doctor in that hospital and worked for a long time, he understood how some of the administration things work, and then they said, no, you can become the superintendent in the hospital. We've realized now that being a hospital manager is very different. You're in the private sector, you don't have a clinician who becomes the manager of the hospital. You have somebody who is specifically trained and skilled to run that hospital, right? So we've realized that, and certainly we have adjusted the system to make sure that the people that are running hospitals have the right skills, and where they're lacking, we would need to train them, and there's a lot that we can talk about around that. So historically, a number of institutions have had problems with how the skills were defined. So who should be a manager of a clinic or a district hospital or regional hospital? That's now defined in regulations. And so but we still have people who are in the system who may not necessarily be appropriate, and we need to move those people out, I guess. And so a lot of skills development happens as part of that process. Effective supply chain. Now, this is an area where you often hear there's a shortage of medicines or consumables or supplies. Well, the problem here is multiple. It could be that the manufacturer hasn't produced, the procurement system has a problem in that the way it was set up didn't allow for delivery of those goods. There's issues of delegation. I don't know if you know this, but in many facilities, the hospital manager doesn't have the capacity to order those products. He needs to ask head office. The famous example the minister likes using is if a person wants to change a light bulb, he needs to go to head office to ask them if they can order the light bulb for him, rather than him having the power to be able to do that. the argument against it from people who don't like doing so is that if I transfer all those powers to those people in the facilities, then you'll have the problems that you have around corruption and fraud. But I think if you have the right systems in place, you can be able to have the checks and balances, and that's where the problem arises. If you look at it, if you compare this to the private sector and the private hospitals, many of the managers there, and maybe some of them that are here who can talk about it, they do have the ability to actually order many of these things. So putting in place the checks and balances is what is key at a facility level. You may know we have a stock visibility system that we introduced around 2013, 2014, that's able to give us visibility of what the stocks are in facilities. It's a novel system, actually globally. I'm not sure of many countries that have it, and it has an early warning mechanism within it so that you're able to identify when medicines are not available. But that doesn't solve the problem where a province doesn't pay a supplier and the supplier is not going to deliver. Or if a province doesn't order in time in order to get the delivery. So you need to plan once the system tells you that you need to order. Let me come to matters of finances. Well, I think on finances, the first key issue is that the health system has been underfunded for many, many years. I know many people would say, well, there's corruption and there's fraud. That's true, there is that. But I ask you to add up all the corruption and fraud and compare that to the extent to which the underfunding has happened. And there's a lot of publications around this. I'm happy to share that. But there's been huge underfunding in the health system, to the extent that provincial departments have massive accruals running into billions of rands. What that means is that every year, as the new year starts and a new budget comes in, they're paying suppliers for last year's expenditure. So they're having less and less every year, right? And so the Minister of Finance actually in his budget speech spoke very eloquently about it. And I thought at the end of that he was actually going to say, well, I'm going to relieve the health system of this problem, but he didn't say that, and that's a great pity. But I do think as well there is a need for the public system to manage the budgeting within its facility. So if you took, for example, the Tembisa case, if at Tembisa Hospital they had cost centers for each of the different divisions of the hospital, they would have been able to detect that something's happening here. How is it that they're ordering so much from this unit when they only see so many patients? You would understand that. But because there's no cost center, things just get ordered, it just gets placed against the hospital. Nobody compares that against output. I also think there's a need for a more prescriptive approach to how procurement happens. Very often in the health system, the public health system, there's no market analysis prior to procurement to understand what price should you be paying for this, how much of it do you need, what is the actual specification, having a digital system so everybody can see what you're buying. You can actually learn that there's a supplier that's selling this much cheaper than what you're paying for it now. But if you don't have a digital system, you're not going to be able to do that. And having a national set of market-rated prices for goods and services. I mean, we know about things like milk and bread and what the prices are, but other goods we don't. And so having that system in place will prevent some of the things that happened. On infrastructure, let me say, I say I'm being warned about time. On infrastructure, let me say we have a huge problem in terms of the backlog on infrastructure. The particular problem here is the Department of Public Works that is responsible for the infrastructure in public facilities. So the Department of Health, when something's wrong, can't go to a contractor and say, come and fix this. It has to go to Public Works. And some people say DPW doesn't stand for Department of Public, it stands for Department of Please Wait. And that's where the problem arises. Long delays before a contract is put in place, a supplier comes in and fixes something. While he's fixing this, other things have now broken, and so the system just doesn't work. So let me talk about the private sector now, as I promised. I think one of the key issues in the private sector at this point is the huge prices and costs within the private sector. And these these high prices, particularly in the case of hospitalization, specialist charges, diagnostics, and prescription medicines, mean that a middle-class worker is not able to purchase these services out of pocket. An ordinary man in the street is not going to be able to walk in and be able to buy those. I think Rowan kind of intimated to that. And I would say the establishment of a multilateral negotiating forum, and there's a lot written about that in the Health Market Inquiry, about how that could be set up and what that could deliver in terms of reducing costs is key. I think secondly, given the need for risk pooling, medical schemes currently are sitting at a flat population level, largely because participation is voluntary. The young and healthy in a system must subsidize the sick and old. But if you have a voluntary system, why would somebody want to participate in that system unless it's mandatory? That's why you need a system like an NHI to be able to deliver that, because people are not voluntarily going to participate in a system where the young and healthy are going to subsidize the sick and old. And so a single risk pool through the NHI will probably solve many of those problems that exist in schemes currently. And then thirdly, on the issue of medical schemes, they have to fund prescribed minimum benefits as they are currently. But they do this in the context of declining members and rising costs, because they can't manage the input costs that they have. The consequence of which is they need to then reduce the benefits that they're offering, increase the co-payments. So the system in its current form is not going to be able to be sustained in the longer term. A more affordable tariff system is what's needed, with negotiation between buyer and seller about what would be an affordable rate. Let me say a little bit, let me say a little bit about billing and the reimbursement rate from medical schemes, which leads to high out-of-pocket expenditure. I think that's a huge problem amongst many people. And so I think the multilateral negotiating forum also deals with that, as well as the way the system is currently structured, where we have a fee-for-service model. If you paid on a fee-for-service basis, you have no incentive to support the outcomes for the patient. So what I'm talking about here is capitation and DRGs, and these alternative systems can voluntarily be implemented by medical schemes and administrators in the current form. I think on the issues of outcomes, and this is what really surprised me during COVID, and I think Professor Crisp was part of that group, when we're collecting data around mortality, the public sector routinely collects mortality data. But when we were trying to get that data out of the various private hospital groups, it's not routinely collected. There's no database you can go to, and because I was saying just upload the data to us, and they said, well, we don't have that. So clearly we're going to have a system to also monitor outcomes in the private sector, because you need to know what are those outcomes. You need to identify those problems and how do we intervene. And finally, let me say, I think that the private sector, by paying higher prices and having the lower workloads, attracts skills away from the public system, which is a huge problem. We can't have two systems that compete with each other, and the basis on which they compete is financing, because I can pay more than you. It's like going into a supermarket and saying, well, I'm going to be paying more for this loaf of bread. There's only a few loaves on the shelf, so let me pay more and I'll take the bread. The guy who can't afford the bread will lose out. But in this case, we're talking about attracting scarce skills in the form of many of the clinicians that are in very scarce supply in our health system, which has huge consequences for the patients that actually need access to their care. So the question is, how do we have a common risk pool so that we're able to access those services so everyone can actually participate in that pool? And I do think that the NHI will be able to equalize this abnormal distribution, both in terms of human resources as well as in terms of access to care as an alternative. I know I've been warned about time, so I'll stop now. Thank you.
Dr. Anbin Pillay, thank you so much. I hope getting to NHI is going to be quicker than getting through your presentation. But thank you so much for your time. I think you'll be forgiven because it was quite informative. To put on my other hat, we sometimes say we'd like to interrupt this program to bring you breaking news. I'm going to do just that. I'm going to pause this program now because I want to acknowledge someone that's here, Dr. SiGLENKT5iT. It's nice to see you. I'm going to come to you. You're special. I didn't invite you up there. It's also not foreign for me to be standing on the other side of you with a microphone, but I promise that I won't be arguing with you tonight. So I'd just like to invite you to say a few words. I'll give you 3 minutes.
No, thank you very much. I came to listen to this panel of very eminent leaders in our country. And I'll have my challenge with Chris, Professor Nicholas Chris. I think from where I am, we need to find a way, and I do know that there are some leaders in this house who would want to say, you know, we are with you in court for just one issue. Can we not find? So we're not finding enough time to talk about those one issues. And half of the people probably have decided to stall the process. Now, we are going to delay to implement something you're not sure whether the court is going to say yes or no. So my real desire is that let us find time in our own little corners to deal with one or two of those people who actually may have just a little bit of what they need, sorted out, and move along. The more the merrier in my space. Thank you very much.
I see you've improved, Dr. Dlomo, in terms of how long you keep the mic for. So thank you so much for that input. Now we can get back to regular programming, and to do that, I also now invite Professor Morgan Chetty to join me up here. These, I was thinking about this earlier, and I was talking to Rowan, and I said that if I had to actually go through the bios of all of the speakers that we have today, we'll probably be here until 9 or 10 o'clock tonight. So I know that you are well versed with who these individuals are and how important they are in this space. So as we welcome Professor Chetty, thank you so much.
Let me start by revealing a disclaimer. I'm not important in this space. And Chris, I'm sorry, I was hyping myself up that I'm going to follow you. That's what I was told. So, ladies and gentlemen, I'm taking a different approach altogether. And the approach I'm taking is I don't want to steal the thunder from the two senior government officials here, Anben, which is Danny's, and Nick was coming next. I'm going to share with you a sentiment that I read in a lot of documents that's flying out. Now we have a famous thing called chat lines. And on this chat line it said, it's very disingenuous for people to allocate time to reform health or to introduce so-called solutions to health. Nothing's broken, so let's go on. And I thought about this very carefully, and I have the privilege of working in Africa, and I want to bring some lessons and say, the challenges and complexities that we have in South Africa are not unique. These are challenges and complexities that we see in all developing and all low-income countries. So I'm going to take you through a little discussion to try and put the best way I feel for us to see the magnitude of the problem is every now and then to share some data with you.
If you'll forgive me, and apologies for this, I'll do it before you get started. I know many of you can tell me how to hold a syringe, but I'm going to ask you to hold a mic a little bit closer to your mouth so that everyone can hear.
I was trying not to have any contamination. So the health systems in the African continent and in most developing and low-income countries face multifaceted healthcare crisis, and it's characterized by a few issues. So let me talk about the issues. It's totally under-resourced. It's not a South African problem. It's a problem throughout the continent and in all developing economies, where you have health system problems and you have human resources. Maybe later in the discussion, we can highlight some of the human resource issues that we face in Africa. It's totally underfunded, and this underfunding, just to put it into perspective, is due to the fact that in the African continent, we depended a lot on external funding. And the South Africa and the governments of Africa didn't contribute sufficiently from the government. And if we look at the Abuja Declaration, the Abuja Declaration said in the early 2000s that all countries should sign a pledge to allocate 15% of the GDP to health, and actually only one country did that. So the underfunding is due to the fact that we didn't manage this properly. Two, we have a very high burden of disease, including recently a lot of disease outbreaks, and this makes the challenge of providing healthcare even worse. We have inequalities and often poor quality outcomes, and we have very limited access to essential services. And I must go back to what Anban said, and it sounds like rhetoric, but poor governance and corruption is a leading cause to why we have had challenges. So this is not just an South African issue, it's a wider issue. South Africa has what we call a quadruple burden of disease, and let me just take you through that, so if those who don't know about it. We have a high burden of communicable diseases and vaccine preventative diseases. We have rising NCDs, there will be HIVs, cardiovascular diseases, diabetes, cancer, mental illness, and chronic lung disease. In fact, we're coming to a stage where the NCDs, the non-communicable diseases, are challenging or surpassing the issues of communicable diseases. We have in this country and a lot of parts of Africa, we have injury and trauma, which is a major contributor. And then we have in South Africa particularly a high maternal and childhood mortality. So these are the issues that are maybe peculiar. So if we look at what Africa is going through in its complexities, we've got to customize our focus on what the needs of this country are for the people in this country. So for clarity, I spoke about burden of disease. So let me just tell you for clarity what I mean by this. The burden of disease measures the impact of living with illness and injury and dying prematurely. So it compromises productivity of the country and it compromises the economy. It measures the years of life lost prematurely. So it is a challenge because if we've got to look at it in that perspective to see that we have major challenges. And people like Dr. Crisp and Anban are sitting in the Department of Health, and people may think that they are trying to impose challenges that are not doable. But the moral of the story, you've got to start somewhere. It doesn't matter how long it takes you. If you have this data and information, you've got to start somewhere to solve problems. So let me give you some data. I want to share some data with you to give you a global picture how serious the challenges are. So Africa has 15% of the global landmass. It has 25% of the global burden of disease. It has 14% of the world's population, which is about 1.4 billion. It has only 3% of the global healthcare workers. And to make it worse, the last stat is even worse. We have 25% of the global burden of disease, but we actually have to spend 1% of the global GDP on health. So it's insurmountable to parts of how do we solve for the problems we have on hand. So against these interlinked complexities, let us review the health challenges and the urgency to create a structure that allows access to all citizens without financial hardship at the point of care. Without access to essential medicines, Africa is susceptible, and South Africa as well, to 3 killer diseases: malaria, tuberculosis, HIV and AIDS. Let me give you another feel for this. Globally, 50% of children under 5 years would die of pneumonia, diarrhea, measles, HIV, TB are from Africa. This is the WHO statistic. So there is an urgency to implement solutions towards establishing a very sustainable and resilient health system in Africa, and this can be further supported by other compelling data. So how big is this challenge that Prof. Crisp and Anbin sit with on a daily basis? And all of us, for that matter, because the solution for health is all of society's solution. Globally, 17 million people die before the age of 70 years from NCDs, and 86% of these deaths are from low and middle income countries. Of the 1 billion of the world's most vulnerable population affected by neglected tropical diseases, Africa accounts for 50% of the global burden. And the diseases in Africa, the last stat we have, has cost Africa $2.4 trillion. And I'm going to tell you as I close that one of the ways to prevent us having to repeat the statistics is to change the way we're going to treat patients in future. Maybe for this discussion, we need to isolate a few important challenges in developing economies, demystifying some of these challenges. We have the things that Dr. Anbin Pillay spoke about. We have decreased pharmaceuticals and medicine supply chains, vaccines and commodities. I'll give you a stat from Africa. Between 70 to 90% of the molecules in Africa are imported. We're not developing enough PEIs, which is pharmaceutical essential ingredients. So a lot of forex leaves the continent because we're importing. We're not manufacturing enough on the continent. And the other big problem we have, and it's not a South African problem, is deficiency of human resources for health. It's a huge problem. You know, we talk about outward migration, we talk about brain drain, but we don't have enough health professionals. And later on, maybe we can discuss about the novel ideas that can be implemented to provide more human resources capabilities on the continent. So the United Nations set the Sustainable Development Goals, and it identified at Pillar 3.8 the need for universal health care. Presently, the G20 Healthcare Working Group are championing that universal health care through primary health care is mandatory, and the B20 Health Task Force is advocating some form of public-private partnership. And South Africa has a unique opportunity to transform its primary healthcare system if we employ these strategies. We also need to strengthen our healthcare systems, digitalize our primary health care, and we got to start using a lot of start employing a lot of task shifting, where we're going to move tasks to other people, like community health workers, to compensate for deficiency of human resources. This task shifting to the others is just the fact that we will be able to provide more services, and it actually is not a challenge because we can use nurses and community health. It's not a challenge because it frees doctors to practice at the top of their license rather than doing things that you shouldn't be doing. The future is about coordinated, integrated care. It's about multidisciplinary team care as the future. I'm not saying this, I don't know if Dr. Crisp is going to say this, but I don't think solo practice is dead, but it doesn't provide the adequate service it should, and we should think about how else we're going to do it. We're going to look at a lot of national and global partnerships and innovative ways of raising money, and we must subscribe to two agendas. We must subscribe to the United Nations Agenda 2030, and we have less than 5 years to reach that target, and the AU's Agenda 2063, which has been set recently. So the South Africa we want is an all-of-society approach. That's why a multi-stakeholder meeting like this is so important because every one of us has a role to play, not just the Department of Health. And it's an all-of-government approach. The WHO and the G20 affirm that primary health care is a cornerstone of equitable, resilient health systems, yet South Africa's model fails short of this. So, in conclusion, I want to say the future is about all of us. The future is about how we can come together. I don't think we're going to be fixing the health system completely, Robin. I'm not sure if Robin is. Yeah. I think we're going to find a lot of solutions of how we're going to fix the health system. And I think that's the intention of tonight. Thank you very much.
Prof, thank you. And now I know you'll take that lesson that I gave you back with you about the microphone. I appreciate it.
I thought you were going to have a more electronically one that will come to you.
Okay, we must talk to Rowan to improve the tech. Thank you so much. Appreciate it. I appreciated the frankness of your presentation as well. You spoke about the issues of corruption and inequality and how it plagues the healthcare system, and I think it's top of mind for most of us that are interested in what goes on there. But Professor Nicholas Crisp is next, and he will join us, and I'm particularly interested in listening to you, not that I wasn't interested in anyone else but you, because you'll be talking about the NHI in particular, because that is your baby. So please, take it away, and thank you.
Thanks very much. Good evening, everybody. And thanks for the invitation. It's my third one today, so I'm a little tired, so hopefully I can keep to the 10 minutes. Please wave when we get to about 8 or 9 minutes, so that I know you want me to wrap up. I want to start by saying we had a moment of silence when we started to recognize health workers, and that's an excellent place to start. Thousands and thousands of health workers go out there every day to look after us, the citizens and the people who live in our country. Often we do not recognize that they are the people who are actually the bedrock of the health system. Doesn't matter if you work in the public sector or in the private sector. The vast majority of these people go out there to offer professional services every day, and they do it to the best of their ability. Can we please, as society, just love them, respect them, and keep them in their jobs so that they don't go and do other things? Now, I want to acknowledge what my colleague Dr. Pillay said as a foundation, because I don't want to repeat where he went. Please go back to that definition and the things that he explained about what we are trying to do globally and in our country to get health care for everyone. So when we talk universal, we are not talking about two universes. We're talking about one universe. Universal means one. Universal health coverage. So we've heard a lot, and Anban spoke a lot about some of the challenges and problems and things that we experience in the public sector, and he touched on the private sector. Can we please recognize that both sectors have lots of challenges? They're different, but they are not only public sector challenges. We recognize, we acknowledge the corruption, poor management, lack of resources, and everything else that goes with what you would regard as a poor quality health service in the public sector. But patients like the minister and like me now have decided we're only getting our health care in the public sector. Why? Because the clinical care is so good there. We'll put up with some of the other things and the waiting and the queues and whatever else goes with it because the clinical care is so good. Those are our professors. Those are people who taught us. Those are the people who made it possible for those of us who are practicing in private to get our education. We need to recognize that. We also need to recognize the problems that we have in the private sector. Runaway costs are a problem. But what we haven't spoken about is having 71 medical schemes with 311 different options that you so-called can choose. So I choose not to have cancer next year, so I'm going to choose this package. I mean, really? You don't choose. It's what you can afford. And if you don't have a big income, you have to choose something that is lower cover. And for most of us, including myself, that might be only in-hospital care and only for PMBs. The rest you must pay out of pocket. Then you must get gap cover or pay cash or raise money or do whatever. And for the majority of people, that's really difficult. 35% of people who are so-called have their lives covered by medical schemes have only a hospital plan. So this is problematic for a lot of people. So there are structural problems. This is not an accusation against this province or that province or the government. It's also not an accusation against this medical scheme or that medical scheme. It's a structural problem with the system of our country. So recognizing that, the question is, what do we do about it? Number one, we go back to the Health Act, which has served us fine since 2003. And it says that there's one national health system. It's defined in the Act. And it says it includes all public and private services, providers, and financing. One national health system. But we don't behave like that. We behave like we are two, and some can go there and some can go here. But sorry, when you haven't got money, you must go there, you must go here, you must do this. It puts us all at risk to behave like that. So what are the fundamentals of the national health insurance? What's different from what we do now? Two big things. One, and Anban touched on this, we need to pool our money. We need to make sure, like a big stokvel, that when you need health care, you know it's covered. You don't want to guess on what you're going to get run over in the street on the way home, God forbid, and then now you've got all of these expenses. You want to know that when you need that health care, you can get it. You do want to know that it's of an acceptable quality, and that doesn't include the menu in your ward and the TV in your ward, the hotel services that Anban was referring to. It's about clinical care. Yes, we want the place to be clean and look nice and so on. So you want to make sure that everybody has access to the common things that occur commonly that all of us need to have covered. A package. The medical science can pay for a lot more of that. Can provide a lot more than that. So it may be that there are things that can be offered which should not be paid for with the taxpayers' money. And we need to make that decision based on evidence. So the National Health Insurance says there must be evidence for what goes into the benefits, both in terms of the package, in terms of the standard treatment guidelines, in terms of the medicines that are needed for those standard treatment guidelines, the devices that are provided, and so forth. That includes the colostomy bag for the person who's got a colostomy. They don't put a Coca-Cola bottle or a Checkers packet over their colostomy because we could only give them one for the next 3 months. I mean, that's ridiculous. Why would we as society tolerate something like that? We shouldn't. So we want a system where we know that when we need health care, it's paid for. So the first thing is this pooling of the money. I'll come back to the corruption and the accusations around that in a moment. The second thing is, which is not prominent in the media, is the purchaser-provider split. The National Health Insurance does not do away with the private sector. In fact, in 10 places, the Act says the fund must purchase from public and private providers. It's not an option. It's a statutory requirement for the fund to purchase. And there are other clauses which make referrals, entry at the primary care level, stuff Morgan was talking about a moment ago, making sure we get preventive health care. We extend our reach of us as professionals, because we're few, by using other professionals and lay people to extend our hands. He didn't talk about digital, but I know AI is on his mind and so on. There are lots of things we can do to extend our capabilities to reach patients, make sure that they take their medicines, they understand what's wrong with them, we prevent as much as possible. But if we keep thinking that they must fix their problems and we're all right, Jack, we're going nowhere. So I really like this. This is not a talk shop. And we are not here to fight. What we have to do is find the common ground. There's lots of common ground. Patient health. Can we please just put the patient, the user of the health system, back in the center? Unfortunately, people have taken stances. Anban showed you Section 27 of the Constitution. In all the court papers, people want Section 11, Section 22, Section this, my rights, my rights, my rights, forget about the patient's rights. The whole court papers are littered with that. Why are we even discussing that? But people have taken stances on it. So the two fundamental things about the national health insurance is, one, pool as much as possible of your resources and run it as one publicly funded system. That's what the world is doing. Two countries are kicking it, United States and South Africa. Everybody else has gone that way. In fact, we've got the G20 meeting next week. We've got Joseph Stiglitz, who's a Nobel Prize winner in economics. We've got Professor Maguire, Professor Yates, Professor whatever, all these global experts on health financing and economics who are coming to share with us what is happening around the world. But no, we're different. We can't do it. We can't do what other countries did. We can. We need to sit down and listen to one another. So far, it's all been the state listening. I want to call him the Honorable Dlomo, because while we were debating the bills in Parliament, the Honorable Dlomo was the chair of the Portfolio Committee. And guiding these debates and listening to people's inputs was all one way. The state listening to other people. There was never an opportunity where people sat down and asked us, what do you mean by this? How do you think this will happen? How can I get involved? Never. So I've been in the department now 4.5 years. Nobody asked us those questions. Nobody engages with it now. I think the time is now. The court cases will continue. By the way, there are 13 at the moment. Last night I got a really snotty letter about stuff that I said in Parliament on Tuesday. Fine. You're welcome to differ with what we are saying. But why don't you come and sit around the table and tell us? Discuss with us. But listen. So the invitation is there. And this opportunity, and congratulations to organizers, sponsors, people who make it possible. We need forums like this. We need small roundtables where you ask us, what do you mean by tax credits? What do you mean by changing an accreditation? Why do you want us to follow standard treatment guidelines? Every country in the world follows standard treatment guidelines. Why do you want to reduce 51% private funding? The UK, by the way, has 3% private funding. Why do you want to increase from 15% government spending on healthcare as a proportion? Canada's already on 40%. You know, we are not crazy. We just need to sit down and find solutions. Thank you.
Prof, thank you so much. I like what you said there. We are not here to fight, and certainly not that. In fact, it's meant to be a situation of working together. And I see that you counted all of the, or some of the possible things that could come up here during the discussion. Very smart, but we're still going to get to more of it. So that brings us to our last speaker, Dr. Imtiaz Sooliman. It's good to welcome you to the stage again. You need no introduction, but we are looking forward to your input. Come this way, Dr. Sooliman. And it's good to see you in a different setting as well.
Thanks. Thanks, Tarzan. Thank you, Dr. Dlomo, Nicholas, Anben, Delhi, everybody who's here. Rowan, thanks a lot for doing this. Nicholas is right. We need to sit and talk to each other. When you speak to the private guys, they say they got investors who want returns on profits. Unacceptable. Yes, they must get return on profits, but not exploitation on health, because people are most vulnerable at that time. Government got its flaws. Yes, we have to fix the flaws. We keep saying government is corrupt. We have to change the narrative. Government is not corrupt. There's corrupt people in government. There's corrupt people in the private sector. There's corrupt people in the religious sector and in my sector and everywhere else. And when we say an entity is corrupt, we wipe out all the good that other good people in the system do, and we destroy their fiber and the desire to work. I will give you what we've been doing in the health system and all these flaws that we have and the problems, how we can find solutions around them. So in COVID, we got involved from the first week. And in the stories I'm going to give you, we'll see where the problems are. And as we started getting involved, we got involved in 210 hospitals nationwide, and all of different things that we did. Scrubs, PPEs, sanitizer, thermometers, pulse oximeters. We went eventually to set up dedicated COVID wards with infrastructure and oxygen. We put in boreholes. We provided food for the patients and supported the medical staff. Healthcare workers for the first time needed psychological support. You know, doctors don't need a psychologist. It's not good for them. They don't go for it. We're too macho. We don't need psychologists. But during COVID, in the medical groups, you saw the doctors were asking who's a good psychologist. And they were breaking down in the hospitals. And we sent in what is called hospital heroes, a means to support them mentally and support the doctors so they can carry on functioning what they're doing. Now comes the question of ethics. A lot of physicians, COVID was a physician disease, ducked their responsibility. They stayed in their offices and didn't come to the front. Gynecologists, orthopedic surgeons, and people in that category came forward. We got a crisis of ethics in the health system, which we need to fix. Whilst doing that, of course, we found crisis in terms of management, infrastructure, maintenance, in a shortage of staff, shortage of equipment and supplies, the ethics itself, and of course not enough resources. All those things had to be dealt with. But Nicholas is right again. We need to acknowledge and applaud those healthcare workers. They said that day and night with no thanks. When a healthcare worker decides to stay in the public system now, with all the challenges that they have, and of course we've got irritating CEOs and irritating heads of departments in a lot of hospitals. Ego is a big issue in government. Sorry, I'm a very blunt guy. There's lots of ego issues in the health department, and you know, they mess around your system to work, and they destroy your functionality. When we started putting things in Gauteng, somebody in the health department in Gauteng got very clever after 2 weeks and said we're going to discuss and have agreement and sign an MOU, this, that, and other. I told him, are you prepared to die? Are you allowed to wait for other people to die? Yes or no? He just kept quiet. I let him keep your form. I'm not signing anything. And we went into 210 hospitals in the country. To the credit of the CEOs of that hospitals, they put the patients first. Now this is where we have a problem. You know, those of us in private hospitals and got private health care, we forget our private health care is only for us, wife and children. Your brother, your sister, your auntie may not have that health care. They need to go to the public service. So why are we harming the public service when our own family has to go to the public service? And those on medical aid, a lot of them can't afford the gap cover, can't afford the full plan as they spoke about, and they land up in trouble. So yes, I'm not debating NHI now. I'm talking from a compassionate point of view. I see the suffering of the people, middle class, lower class, and people in all categories. And we decided, how do we find a middle way to support the government structure and to get support from private sector? To be fair, there's been a lot of changes in the thinking in the private sector. You now find that hospital groups are coming forward and saying, please take our theaters in the weekend. We've got enough capacity, 35% extra capacity. We will put our staff to support you because they're getting paid in any case. So we don't have to pay them anything extra. They're already paid. We may give some consumables, but we can't give too much because the guys who invest will say it's affecting the profits. Right? Open about that, right? We understand that. And then they said, let's go one stage further and use our own private doctors within our own hospital system to help the public sector. Some issues have come up about that. One is sometimes the hospital, the public hospital, is not very keen to raise its patients to the private hospital. Sometimes the medical guys in the public hospital are not very keen for the private guys to operate on the patients. The other way around, where we say, okay, we will take private doctors into a public system, many of the hospitals have welcomed that. But then some of the health departments come up with this crisis or this obstacle. No, they need private insurance, additional insurance. Now the doctors are already giving free time. They're losing their patients, their own patients in the private space at that time. Now they have to pay the extra insurance when they come. That's a system the National Health has got to look at. But we found that some hospitals found a way of overcoming that system and allowing the private guys to come in. And when the private guys come in, it makes a huge difference because the public guys are burnt out. They're exhausted, they're tired, they need all that kind of support. So it makes a huge difference. I'll just give you one or two examples. Cataract surgery in Eastern Hospital in the Western Cape. Dr. David Stephen is a public hospital doctor. And he said, although we're overworked and my staff are overworked, we prepared to work on Saturdays to catch up the cataract surgery. Peter Wharton-Hood in the Life Group also started doing that, catching up cataract surgery. He gives an example of one couple. The lady takes out a bandage, and for the first time she can see, and tells the husband, "You've gone old." The husband takes out his bandage because they were a couple, and he looks at her and says, "You've gone old too." That's the funny part. The tragedy is they lost 8 years. They lost 8 years between themselves to see the children, the grandchildren, productivity, and everything else. And how long does the procedure take? 8 minutes. They lost 8 years for 8 minutes. This is not acceptable. I can't blame the health department because they're dependent on budgets from the National Treasury. I can't blame the finance minister because everybody else is asking for money too. And the government's got a shortfall because 7.4 million people's taxes can't look after 65 million people, no matter who the government is. It makes no difference because we just don't have enough money. Yes, they're going to take account responsibility for corruption. They're going to take accountability for fruitless expenditure, 400 billion a few years ago, about 200 billion every year. They need to fix that system. That's their problem. But in spite of that, we need additional support. And we need to have a compassionate support in the system. I mean, some of you guys in the private sector charge 3 to 500% of the medical aid rates. That's criminal. I'm being blunt. It's ridiculous. How much money do you guys want to make? People come there battling and with difficulty. The private companies charge the government sometimes much more on the equipment than they charge anybody else. Not in medical equipment, but I'll give you an example. We put an AstroTurf in the northwest province. One of the MECs said, "Very good, you got 10 million rand, you're going to get one AstroTurf." So I got shocked, asked, "What are you talking about?" She said, "It costs 8 million rand. I said, "What costs 8 million rand?" She said, "AstroTurf." I said, "No, it costs 800,000 rand. There was a 10-fold increase in the price because it was somebody from the government sector. So then what we say, government doesn't give enough money. I'm not protecting the government. I'm brutal with them and I have to be with them, but where they're right, I'm going to support them too. They're not saying, we go to the hospitals, no, government doesn't give enough money, there's a shortage here, money is being wasted. But they're being ripped off by a lot of people. I was in Steve Biko last week. The pharmacy store was full of medicines. Where did this come from? From the private sector. There was enough medicines and they needed more warehouse space. That CEO in that hospital is doing an excellent job, making sure things are managed. Extra surgery, we now support Saturday surgery in that hospital. And I want to applaud one doctor, an anesthetist called Dr. Aisha Osman. She works in a private healthcare group in 4 different hospitals. She is the driving force in the public sector. Takes off on a Saturday to come to the public hospital to make sure there's catch-up surgery. This is a private doctor. All of us can do this. So in short, we can ask the questions afterwards. We've been getting involved in infrastructure development, in boreholes, providing equipment, bringing staff in the weekends, paying for catch-up surgery, paying for other supplies, and doing a whole range of different things. In COVID, we delivered 5,000 CPAP machines designed by our government, by our engineers, for our people. It was far superior than the high-flow nasal oxygen machine, which takes 80 to 120 liters per minute, and those big oxygen cylinders, boom, get empty very quickly. The CPAP machine took 10 to 30 liters per minute. You don't need an ICU, you plug it above your head in the bed. To the credit of the private hospitals, I spoke to the Solidarity Fund. I said, this is not about profits, it's not about private or public. We need to save lives in the country, it's about human beings. Can I give these machines to the private sector? It took them 2 minutes, and they said yes. Gateway Hospital, Life Group, Mediclinic all started taking the machines to put in their beds, and they opened up like 100 extra beds per ward, per how many wards on the floors they had, to put extra patient machines to save lives. They made a difference. Coming back to the story of Nicholas, we have to do this together. There is no other way to do this. The final story, which was absolutely disgusting. I went into Settlers Hospital in Grahamstown. I traveled to a lot of hospitals during COVID. In Makanda, Grahamstown, I walked into the Settlers Hospital. The acting CEO takes me around. I see one ward is shut with a chain around it. So I said, lady, what is this? She said, it's a high care ward. I said, in COVID, your high care ward got a chain around it. What's going on in your hospital? She said, we can't use it. I said, why? A private hospital group was partly involved in that ward. And they said the government's owing them 50 million rand. And the government is saying they don't owe them any money. There's some discrepancy somewhere. I said, but people are dying right now. That we can discuss later. No, we can't open it. I said, where's the key? I'm opening it. So I took the key and I opened the ward and I went inside. Civilized medical people, supposed to be rational. They're in healthcare. They're in saving lives. They ripped the oxygen lines out of the roof. They damaged the ventilators. They damaged the monitors. Is this what prophets make you do? Become inhuman? I said, can we fix it? She said, you know what the answer is going to be from the health department? The budget is finished. Standard procedure everywhere. I said, I'll fix it. Can I fix it? She said, yes. No agreements, no documents, nothing in writing. In 24 hours, my teams were on site. Within 48 hours, we had a 30-bed high-care facility available inside Makanda. And you know what the advantage of that was? The private patients didn't go to PE. They came to a public hospital. And it's right. The best academic care is in a public hospital. If you get involved in a trauma, you probably die waiting in a private hospital, sorry. You're far better off in a public hospital because the guys are on site all the time, consultants and registrars to help you very quickly. We have to balance the two. There's a way to do this together. Got to get the ego out of the system. Got to be able to be share and be responsible and talk to each other. Nicholas, we need to set up a table where the private guys come and talk to you one-on-one, you know, because there's lots of innuendos. You think of imagining things. People is not there out to destroy you. The private sector cannot go. Everybody is required to work and save this thing together because it's the lives of our people. Start taking the profits out of the system and start thinking humanity and compassion. We will make a difference and everybody will survive. Thank you.
Dr. Suleiman, thank you so much for that. You know, you would think with the kind of work that you do, you would be highly critical of government and its failures in some sectors, but that wasn't the message that he was bringing across. Instead, it was a message of working together, a symbiotic relationship between the public and private sectors. And I think that for me is one of the key takeaways, that you mentioned a doctor as well that spends her private time actually helping out in the public sector. So I think that's a message to take away from here, and I think it's a lesson that many people can learn. There were some interesting points that came up during this discussion. I won't bore you with all of the details once again. I'll just tell you what stuck out for me. I did enjoy your presentation, Professor Crisp. You said it's your third one today. Hey? I wonder what the first two were like, because this one was quite entertaining. But you know, what I took away from you was talking about how the private sector won't be left behind. You'll be pooling this money. It'll be compulsory to purchase from the private sector. And I think that again addresses one of the fears that exists in this space about what happens next. Will all of the private healthcare service providers just fall by the wayside? But that's not actually the case. Prof. Chetty, also being quite honest and speaking on a broader scale, talking about the challenges and the success stories in other parts of the world. We sometimes think that we are working in isolation here, and that's not the case. We're not the only ones to do it. Professor Crisp, you also mentioned that. And, you know, I think when Dr. Pillay, you spent a lot of time talking, giving us the groundwork or setting the tone, telling us about the healthcare system as a whole. Because Rowan actually mentioned that to me before I came up here, and I said, look, we're talking NHI, and he's like, no, but we're not just talking NHI. We're talking about what NHI is going to exist within, and that is the space that we are in, and that's why that conversation was equally important. And I liked Ms. Ngobo's tale about her journey, starting a business, trying to get to a point where she's also servicing patients, she's working in a very remote area, and I think that's a really important part of the kind of work that you all do, and that is reaching everyone in every corner of the country and making sure that we get to that point where we will have equal and inclusive healthcare. So I promised I won't speak for too long. That is all I'm going to say for now, but I will say this, we have something special for you. And that will be, no, it's not the dinner, that's also special. But before we get to the dinner and before your stomachs start rumbling a little too much, let us get you there with some entertainment.
Oh,
Thank you so much. Okay, that definitely woke you up. So, you know, I didn't have to read much of anything else, but I have to read this. I'm not good with these announcements. So, Rowan says that the halal food is behind the pillar. He's hidden it away. And then, so no one else gets into it. And then the other dishes are on the right. See, I got that right. Let's hope I didn't mix it up. You'll figure it out when you get there. But please, do help yourselves. Can we start at the back of the room? And let's work our way towards the front as you grab some dinner for yourself. And then get ready for the discussion that's going to take place here. We have already received some questions from the audience. We're going to try to accommodate everyone. There's a number. Yeah, there's a number up here. That's Rowan's number. Please use it for nothing else other than the WhatsApp questions. I know it might be tempting. If there's anything insulting, don't send it his way. But please, send your questions, your comments. All of it is welcome. We'll try to include it, and we'll have it in that discussion after dinner. See you on the other side. Thank you.
Thank you, Baya. That was amazing. Yeah, so I think the dinner,
Yeah, that's cool.
not from the looks.
Okay. stay alive, man. Shit, man. Thank you so much, guys. Thank you. Good. Hey, man. Already, you know, there are people that are not happy with the stuff we do, but what are you going to do? But just keep going, man. And hopefully, hope that all these people that are working with the have my back. You know what? It's in our nature, man. That's why I was saying, I'm not designed for a podium. Like, we don't it's what I was even telling you, man. I was saying, the thing is that this is, yeah. If I could help it, I would move to the crowd. But that's okay. Rather than being stuck here. So, but it's like I said now, I'm like directly with the motion or something. But if I say, hey, what car is talking about cars and whatever, it's fine. Yeah. Hey, man, I told someone I did an interview yesterday. Some guy doing a talk show interviewed me, and I said, guys, don't use the word celebrity and influence. I'm not that. That's not me. So yeah. But what I mean is like, I always say I want people to be in love with my work. I don't want them to be in love with me. I want them to be in love with what I do. So when people come to me and say, man, I enjoy your work, that is me. Not that, hey man, you know, I think you are like a celebrity or influencer or whatever. We're not here for that. So that's why, like, we keep it personal. Yeah. By the way, I do use the helicopter when I get but not for like the local stuff. But like, let's say like, there's something happening, maybe fundraising or whatever. We can't get it, I have access to it. But then other local stuff I drive. And then we also move around like in other provinces and stuff happens. For less. First time. For less. It was imagine. The guys working with the camera guys. Hey, I'll post it like I think something might happen tonight. Because I'll be in touch. I'll be like, just keep it moving. So, then I phone at 3 in the morning. I'm like, let's go. Let's go. You got rest time. You got sleep tonight. Your name, my brother? Sis. No problem. Shut up. Just give me a shout out on occasion. I do that. Sometimes I say to people, you know what, I don't get to engage with everyone, but if I meet someone personally, I always say, just
Good evening, ladies and gentlemen. Please do continue to eat the food that smells absolutely divine. I am Praline Ross. I'm the South African ambassador for World Digital Detox Day. Please do continue eating. This is a global movement that was started about 3 years ago by an amazing lady from India, Dr. Rekha Chowdhury. This movement has over 70 ambassadors throughout the world, and we focus on creating an awareness of the need to take a digital detox for your mental well-being. In a world filled with AI everything, sadly mental illness is on the rise. Suicide is on the rise. We encourage people to take the time out and to know when you've had enough, and there's always somebody out there to speak to. So on my side, I am a mindset and heart set practitioner. I focus on the power of thoughts and emotions and their impact on our behavior. So on the one hand, we have a medical approach, and on the other hand, I believe that the body has a natural ability to heal itself, and I take a deeply spiritual approach to healing. And I often have people saying to me, Praline, I need your help. And I say, sure. I need your help, Praline, because you see me smiling at church, you see me smiling in the choir, but nobody knows that last night I held a gun to my head. And what stopped me from pulling the trigger was my little baby brother and sister who came knocking on my door. This is the reality. There are people here today who have got serious challenges, mental health challenges, maybe going through a divorce and you end up in a dark space and you feel like you cannot go on. There are people who care. And I dedicate this song to you. I dedicate this song to all the amazing people out there, the good people in the world, who just want to leave the world better than when they entered it. I dedicate this song to all those battling with mental health. And I'm doing this first song a cappella without accompaniment to showcase the ability to heal through music. And the song is called Smile. All I ask you to do is smile. Smile, though your heart is aching. Smile, even though it's breaking. When there are clouds in the sky, you'll get by. If you smile through your fear and sorrow, smile and maybe tomorrow you see the sun come shining through for you. Light up your face with gladness, hide every trace of sadness. Although a tear may be ever so near, that's the time you must keep on trying. Smile, what's the use of crying? You'll find that life is still worthwhile.